I'd like to present to you, which I've left to the end of the list of research trials because I think they will very much blend with many things I'm going to say later today, and also bring us back to the very earliest investigations by the osteopaths at the turn of the 20th century. And this is one of those two pieces of research. It was done back in 2005, looking at the effect of osteopathic treatment on an extremely vulnerable cohort of patients, those who literally just completed coronary surgery, bypass graft surgery. And it investigates the hemodynamic effects of osteopathic treatment, looking at the changes in cardiac function and perfusion, finding very positive changes of function and perfusion, suggesting that osteopathic treatment, even when the patient was sedated and pharmacologically paralyzed because of the surgery, it still had immediate and beneficial hemodynamic effects. Now, obviously, if the patient was sedated and pharmacologically paralyzed, you're minimizing to a very great degree the placebo effect. Now, these hemodynamic effects affected the speed of their recovery after the bypass surgery, and suggest that these vasomotor effects are probably something that were already observed, as we're going to look at a little later, by the early osteopaths when examining on biopsies of the models, the animal models that they experimented on, that one of the first and most important findings was that dysregulation of the vasomotor system, of the hemodynamics of the body, was one of the earliest signs of somatic dysfunction. We'll look at some of those biopsies a little later. But this ties in with those early investigations that something profoundly affecting the hemodynamics of the body and the vasomotor system goes on when you handle the body osteopathically, particularly in the acute patient. Now, the last piece of research I want to draw to your attention is extremely important for all of us, because we're all handling pain syndromes as a major part of our day. But it's a frequently forgotten and underestimated aspect of enhancing the body's immune response to infection or inflammation. That is the ability to reduce the pain that often accompanies the disease. If you can reduce the pain, the body's immune response is more efficient, more effective. We'll look at why a little later. Now, a very fine research worker in America, osteopath called Degenhardt, in 2007, did a very important study, and certainly for me in the pain clinic, I present this to my head of department, and he's interested. He's alert to the possibility that osteopathic work does have measurable results, not just relying on the patient's report that they feel better or they don't feel better. Something can be measured scientifically. And Degenhardt and colleagues at the Still Research Institute in Kirksville published the results of an important prospective blinded assessment trial showing that osteopathic treatment altered the concentrations of several circulatory pain biomarkers, particularly pro-inflammatory cytokines and anti-inflammatory cytokines, for the better. Lowered pro-inflammatory cytokines, raised anti-inflammatory cytokines. Furthermore, and this ties in with what I was saying earlier about the acute sensitivity of the acute patient to being handled, the degree of these changes, the beneficial changes in pain biomarkers, was greater in subjects in pain. Those who had pain were chronic low back pain patients, In other words, their response was far greater in terms of a rise in pain biomarkers than in control subjects without pain. This is your bread and butter. This is our bread and butter every day. Chronic pain patients, sometimes acute pain patients, they respond with measurable pain biomarker release and changes far more than a healthy or relatively healthy model. So I do hope some of these trials, basically what I just said. I'm hoping that some of these trials will have at least sparked an interest in you, as Vichardani suggested, of going back to the old texts and looking them over carefully, perhaps stimulating research that you might want to do yourself to confirm or refute what they were suggesting was going on so widely in their work. And if it influences the course of British osteopathy over the next 50 years, all the better. But the road back begins in the faculties of each of our training colleges and in the future programs of our postgraduate courses. That's where it begins. It does require, though, it requires will, it requires motivation, and one other word, the most difficult thing of all, humility. Humility to radically change direction. Whether it to be found is another matter. Only history will tell. Let's move on. Let's look at three statements. I want to present to you three remarkable statements, three propositions that Patho made in his unique way, because he used the English language very carefully. He didn't say a word without giving it thought. He said very little, but he wrote a hell of a lot. And this was his first statement. I've taken the liberty to slightly reformulate it in more modern English. It suggests that the spinal column and its attachments are often the center for the expression of disease. Now, he was saying this at a time when osteopaths were saying, very often, not still, but many of his students were saying, the spine is often the cause of disease. Which I'm saying is rubbish. It's stupid. He was talking about the environmental effects on health and disease before it became fashionable, 100 years before it became fashionable. He was talking about the importance of diet, clean air, adequate rest, the emotions, as being just as important. That term adjustment means we have to help the person adjust to his environment, not just adjustment on the spine. He's saying, but it's very often the center for the expression of disease, which ties in with the BMJ article, that there is often a somatic component that is expressing the disease going on within the body. It can be picked up if your hands are sensitive enough, and if you look for it. I want to look with you just how remarkably insightful this statement was in terms of modern research in neurophysiology. Despite it being formulated so long ago, we're going to look into it quite deeply, this statement. His second statement: disease begins on the sensory, afferent side of the central and autonomic nervous system. Let's just look at that slowly for a moment. Try to take it in. Disease begins on the... It took me years to understand this. Disease begins on the sensory, afferent side of the central and autonomic nervous system. What is he actually trying to say? Well, here it is in my efforts to put it into modern physiology. In a disease, you've got irritated primary afferent nociceptors. Anyway, in any disease, whether it's inflammation or infection, primary afferent nociceptors will be stimulated by the infection or the inflammation. Within the irritated somatic or visceral structures. That in turn initiates a surge of aberrant afferent reflexes. This in turn triggers upregulated neuroendocrine transmission to the spine and brain. Only then, in turn, does this initiate a train of efferent responses observed clinically as the signs and symptoms suffered by the sick patient. The disease or illness of the acute pain syndrome starts off on a very low level, but on a level that's producing this tremendous input along primary afferent nociceptors. And that's, I think, what he was suggesting, that almost all disease begins on the sensory side. But that has tremendous clinical significance of what you do on the table. And you have to try to appreciate that. Because almost all treatment that I can think of at the bedside of the sick, injured, or infected patient was recommended to begin and end with treatment and technique which were inhibitory and palliatory in nature, to dampen down this massive aberrant input on the afferent side. Almost all treatment of the acute patient, whether it's orthopedically acute or whether it's constitutionally acute, was primarily palliative, sedative, analgesic, as its first concern, and only later were there other stages in the protocol of treatment. The emphasis time and again is on sedation of the massive aberrant input on the afferent arm of the cerebrospinal reflexes, using slow, rhythmic, oscillatory leverages and fulcrums to dampen the reflex and nociceptor overload. Or precisely placed rhythmic, intermittent manual pressure over specific nerve centers, such as the celiac plexus, or the vagus, or the cervical ganglia. And I'll show you some historic photos in a moment of that being done. Taken by still students while still teaching in the background. This is 1906. Here we go. Ready? Ta-da! Okay. There, the individual, the operator, is trying to induce vagal stimulation to activate the parasympathetic side of the nervous system. And we're going to look at, in a moment, another picture of sympathetic inhibition. What's happening here? He's applying deep, sustained, rhythmic pressure directly on the vagus, at the anterior border of the sternomastoid muscle, at the level of the cricoid. That's where it's most accessible to your fingers, to your thumb. Every neurologist in my department uses drugs and is continuously researching the latest drugs on the market to produce that kind of an effect for sedation. Trying to affect the parasympathetic arm of the central nervous system. And there it is, under your fingers. If you know how to do it. Now what's he doing here? Well, this is where he's going to get to the superior cervical ganglia. How does he do it? Deep, moving pressure on the tissues of the neck against the TPs. Got to do it gently. The second and third cervicals. That's where you can most closely approximate to the superior cervical ganglia. You have to move the sternomastoid slightly superiorly and away from your thumb to get in behind it, close to the TPs. Obviously, don't press hard, otherwise it's painful. Dealing with a nerve ganglion under your fingers. That earlier model in the hospital is a colleague who to this day still suffers very badly from irritable bowel syndrome. He had another infectious condition at the time, but he also had irritable bowel syndrome. One of the most effective ways of treating an acute attack of diarrhea in irritable bowel syndrome isn't any fancies that work all over the body and spine. It isn't. There are acute conditions where you've got to work just like a physician applying a steroid. What I did to see him through the day, or the 2 days that he was in real difficulty, was deep pressure to the celiac ganglion, through which all the sympathetic impulses to the gut have to relay and pass. My thumb is moving from 12 o'clock round to 9 o'clock, then a slight release from 9 o'clock to 12, then back again, the pressure going deeper, until you feel, and I'm not joking now, until you feel very clearly the aortic impulse under your thumb. You come down as far as you can till the aortic impulse is as clear as possible. And then you know you are directly, millimeters from the celiac plexus, known as the abdominal brain. That's how important it is. It's second only to the brain in terms of its being the king's cross and St. Pancras of the sympathetic nervous system, and the parasympathetic, and certain convergence there. What could be more undramatic than that? Yet what could be more dramatic than irritable bowel syndrome, with his diarrhea, and his bloody diarrhea at that? That's 1906, that's 1900, that's 1889, when Kirksville Hospital was first founded. It is as up to date today, because what's the drugs that they're trying to give him, or would want to give him? Well, they give him a number of drugs. They'll give him opioids to deal with the pain, and antispasmodics to deal with the diarrhea. And they'll possibly use a large cork. No. Sorry about that, I carried away. Okay. Here's another technique that's as old as osteopathy and yet as current in osteopathic practice if you're working at the bedside on acute patients as can be. It's deep inhibition of the erector spinae, moving the erector spinae laterally away from your thumbs, just like the technique I did from underneath the patient, but now with the patient prone. In this case, the patient is saddled prone over the sides of the table, which is very rarely done, but the patient can be lying normally on the tummy. And this deep pressure from spinous process to the TPs of the same segment, which means it's 1.5 vertebrae up, moving the erector spinae ahead of your thumbs. But it took me years to understand what nerve is trying to be reached, or nerves. How do you explain that to a neurologist in the department? What the hell are you doing, he says. Well, I'm giving it to you on a plate. There's one nerve here, and one nerve alone, that is the lifeblood, the bread and butter of our work, or of anyone that tries to treat anyone with their hands. There is one nerve and one nerve here alone that pays for your mortgage. I've given the name away at the top, and it's this little nerve here. It's the medial branch. Sorry, the lateral branch, not the medial. The medial is the motor. This is the sensory branch of the dorsal ramus. This, where's my arrow? Here. That one. And it lies just beneath the skin, which is where you put your hands when you do any work in osteopathy. That little nerve is all you've got, apart from the ganglia, which I was showing you. That's the only nerve you've got to pay for your mortgage. Bringing enough for the wife to spend on her clothes. She's not here. No, she's very good. That nerve allows your afferent sensory, your afferent input, your motor input through your hands to pass to spinal nerve, pass to a major site being researched today in terms of pain syndromes, and we'll look at it later, dorsal root ganglia. When my colleagues in the department inject their analgesics or their steroids in a partial nerve block, for some very intractable pain cases that we'll look at later. And I'm very grateful for them for being able to do that. We'll see why a little later, why some patients are just so far gone, such pain, they often want to commit suicide. They're trying to put a needle in here to cover not only the spinal nerve, but also to affect the spinal root ganglia, which is seen as a major site for what's known as neurogenic inflammation and pain. From that ganglia, obviously, you're going to go, and that is the only way you're going to get to the spinal cord nerve cells for viscerosomatic or somatic or visceral reflexes. From there, you go straight up to the brain if you want to affect the higher cerebral centers. We're going to look at how you do that later in terms of inhibitory impulses to come back down, pain relief. And from there, of course, you're going to come back out and try to affect the rami communicantes, which we'll look at later again because they're particularly prone to suffering from myofascial compromise. And of course, from there to the sympathetic ganglia. That's your only input manually. There are other ways of affecting the structures, which we'll also look at later. There's one other little nerve on this list, which I haven't mentioned, which is being researched again very, very much in the past few years. Yet was talked about back in the turn of the century, 20th century. In those days it was called the nerve of Luschka. When you read up the notes and the textbooks of the early osteopaths, they were very interested in this tiny little nerve. No one else was. But boy, are they interested in it now. If you want to read up about it, here's how open-minded I am. If you want to read up about this nerve, go onto the internet, into the website of a chiropractor. And his website's called ChiroGeek, G-E-E-K, ChiroGeek.com. He's a chiropractor in America who suffered terribly and has undergone back surgery. And he's devoted a hell of a lot of time to producing a wonderful website for understanding back pain. But he's as up-to-date as possible in all the research that's being done with back pain, acute and chronic. Well worth reading, has a wonderful section on reading MRIs and CTs. If you don't know how to read a CT or an MRI, you can start in no better place than reading how he takes you by the hand, helps you read CTs and MRIs, which is called on his website. But he also points out some of the very valuable recent research being done on this recurrent meningeal nerve. Do you know where it is? It's so tiny you can hardly see it. It's this tiny little structure coming back in here. It's a mixed sympathetic and sensory nerve. It's the sensory portion that has been interesting to researchers recently because it supplies nociceptors. It relays nociceptors found in the external surface of the spinal disc, intervertebral disc. It relays nociceptors in the longitudinal ligaments, and it relays nociceptors in the facets as well. But that's another story. Let's just continue within the spinal cord. In other words, most of the pain coming from within the spinal cord is relayed along the recurrent meningeal nerve, this tiny little snip that goes back in through the spinal foramen. It's a fascinating little nerve. I can't claim to understand it all. It's worth looking at when you have the time. It's not on the internet, you can find it. You don't have to go through massive textbooks to find it. But ultimately, as osteopaths have been saying from the beginning, and we'll look at that again, why it's so current, you've got to try to affect what's going on in here, in the spinal cord grey cells. I'll see why literally. Here's another statement of his, the third statement. It's extremely relevant in regard to osteopathic technique, and it's the most difficult of all to teach. How do you turn a purely physical act of putting your hands on the body into one that produces profound physiological responses? In other words, when we put our hands on the patient, on the body of the patient with an intent to treat, it has to be done in such a way that will convert that contact into one that produces profound effects on the processes underlying the disease or injury being treated. Furthermore, it has to be done in such a way that causes a train of therapeutic effects that should last hours, days, or even longer. It's the most difficult thing of all to teach. And you can feel the difference immediately between a young novice, a student putting his hands on the patient, and a teacher doing the same procedure. The difference is obvious if you're the model. It's even more obvious if you're in acute pain or very ill when you're so sensitive. But there is a definite, clear, osteopathic way of handling the patient, of the body. And I was struck by this very early on because I had the privilege not only of having John Wernham as my mentor for 16 years and treating me even when I was well just for the sake of learning from him for 16 years, every week, and treating him, getting feedback, but I had the privilege of learning for a few years before he died from his teacher, or one of his teachers, apart from little John, which was Edward Hall. And it was amazing. There was a distinct and clear similarity of touch and handling. And one of the proudest moments in my life was when a student of mine, who happened to also have had treatment with Wernham, said, "Michael, your touch is so similar to John Wernham's." And then I picked it up on some of my students who've advanced through their training. That at a certain stage, there's a certain skill that is clear as I don't know, a disciple of Rembrandt's, or a disciple of a great pianist. There's a sound that's produced by a good musician that is clearly professional, as opposed to amateur. Now, if you can't achieve this goal, then what we're doing is nothing more nor less than massage, bone setting, or an expensive and time-consuming placebo effect. Let's try to look at this mechanism that does convert the physical into the physiological. There is a name for it in modern physiology. It's amazing how up-to-date it is. And this is it. It's called mechanotransduction, a lovely long word. You float that around in a conversation with scientists or medics and, you know, they'll give you a hearing. What do you do for a living? I do a bit of mechanotransduction. It sounds really good. Put it on your passport next to profession. You know, I'm a mechanotransductor. It's the process of, we'll look at it more carefully later in the day. It's the process of converting a mechanical stimulus into a cellular response, and obviously it plays a critical role if you can do that in many physiological processes. We're going to look at those processes later. Just to give you a taste of what's coming a little later. Okay. Now. Let's begin now by looking at possibly the most widely used phenomena in osteopathy. Let's try to explain it. So you can't just throw this term at a medic, at a scientific meeting, and say I'm treating somatic dysfunction. What do you mean, somatic dysfunction? But it's the most widely used term in osteopathy today, as far as I can tell. What does it manifest as? That's what they're interested in. What is it? It's a number of things. It manifests clinically as abnormal changes in soft tissue tone. We've already mentioned that. Temperature, we've already mentioned that. And pseudomotor activity. Now they love that. If you talk about that quite early on in your conversation, they'll give you a hearing. It may appear palpably as edematous, cool and damp myofascial structures, or atrophic, thickened, hardened, fibrotic, dry, and unduly warm connective tissue under your fingers. And there is usually an altered degree of sensitivity, hyperalgesia, at the site of dysfunction. But occasionally analgesia. I'll tell you just a quick funny story about this last point, this usual degree of hyperalgesia. one of my proudest moments in recent years in the clinic where I've been working for 8 years now has to be finally to be called in by the head of the department and others to examine a patient they're seeing, to determine precisely where they should put the injection. They want to know, should they put the needle into the facet joint, or should they be treating the spinal nerve, or should they possibly be looking at other myofascial structures, such as trigger points. So it's a very proud moment. It was a very proud moment when the head of the department, who's a brilliant neurologist, he's a professor, and a young man, he's younger than I am, I'm only 40, said, would you come in and examine this patient and tell me where I should best do the partial nerve or the selective nerve route? Well, is it at L5 or L4, or is it at L3 possibly, or is it down in the sacroiliac? Is that the pain-generating tissue? That was a proud moment for me, partially. The other side of the coin was, of course, here I am helping him do things which I don't think he needs to do if you only give me time with that same patient. I very often think I could help the patients that they're injecting all over the place. So he's asking me, with the skills that we develop in our palpation, to determine where is best to place his needle. Because usually there's a degree of hyperalgesia if you can bring it out, if you can introduce or induce a motion pattern or an articular angle which is particularly sensitive in that particular patient. Let's continue looking at the characteristics of somatic dysfunction. The next one is extremely important, because very often my fingers cannot pick up all the other things that I've said that you ought to be able to pick up, and you could pick it up on that patient as a model. But sometimes it just doesn't exist, or I can't pick it up. I'm not particularly skilled to be able to do that necessarily. But what I can suggest you can pick up very much more often, particularly in the little infant or the child where you can't feel a thing, is abnormal very often. It's just so doughy, so soft, so yielding that it's very difficult to find the pain-generating tissue or the somatic dysfunction. But what you can find, if you stay awake for it, if you look for it, if you are alert, that's a better word, alert for it, is the following. You will often find palpably altered, usually decreased, sense of ease as you introduce movement through the parts of the body. Particularly a change of rhythmicity, a certain loss of rhythmicity of movement as you apply an arc of movement, an oscillatory movement. And of course, you may find a change of the range of motion at the site of dysfunction. But particularly, this loss of rhythmicity is picked up by the fact that it's a whole range of conjoint anatomical structures and attachments that are related to the area that's most sensitive or painful. And that is what you're chiefly trying to diagnose. What are the related structures around the painful area working as a unit, as conjoint structures, in terms of the physiology of joint movement? What are they? Where are they? How many of they are involved? At what angles are they most likely to be arrhythmic or sensitive? Another point that does come out, but is often misinterpreted terribly, because it doesn't have the significance that it's supposed to have, and used to have in the old osteopathic literature, where I'm very critical of what was claimed, and that is anatomic asymmetry at or near the affected region. It does exist, it does appear, but it's brought on usually by abnormal changes in tone and tension, chiefly of the muscular ligamentous attachments. If an area is painful, usually there's contraction, usually asymmetric in the muscles and soft myofascial structures in and around that area. And that alone will often produce, traditionally, the very frequently seen antalgesic asymmetric scoliosis, but will disappear as the pain improves. And one final thing which is very important, but again not given sufficient significance, I believe. There's an alteration in the overall level of tonus exhibited throughout the body musculature. Now you all know that, it's instinctively know. When you're in pain, you respond by inevitably tightening more or less of the body muscle. I had a fantastic experience of this myself just 3-4 days ago. I twisted my knee very badly about 8 weeks ago. It seemed to be recovering very well. There was always a niggle, there was always a bit of a pain, but I tended to ignore it and got back to my sporting routines, including running, which I've loved all my life. I ignored some of the telltale warning signs. 4 days ago I went for a run, and I had to stop in the middle in the most acute pain in my knee. Since when I've been nursing a very sore, painful knee at certain angles. What was amazing how for the first 2 days my whole body was tense. Obviously concerned not to make the condition worse by getting into the wrong angles. But more than that, there was a degree of tension due to the pain. And the patients we see are very often in that condition for years. So one of the most significant responses to somatic dysfunction, inevitably, is the exhibition of degree of hypertonicity in the body musculature, often more so in certain places. But occasionally, when the condition becomes chronic, there is this condition of hypotonicity. It's as if the body's given up the ghost and just melts away. But it's much rarer. I shouldn't have put that up on the screen. I was going to suggest, I was going to ask you a question. I was going to ask you, point out to you that there is one essential physiological process, one, that underlies almost all the above signs and symptoms that we ever see, or that I showed up on the screen in clinical practice. There is one physiological process that underlies almost every pain syndrome you will ever see, and almost any constitutional condition that you will ever see. And it is, if you didn't catch it when I just finished on mistake, the inflammatory process. And again, when I talk to my colleagues about what it is I'm trying to affect, if I bring this two-worded statement up, they'll listen. Because they're constantly trying to dampen the inflammatory response, because that's what's causing much of the pain and symptoms of the patient. And they're doing it usually with steroids or with non-steroidals. But remarkably, following the findings of these early clinical biopsies done by the osteopaths at the turn of the 20th century, many of them could detect from those biopsies and correctly attribute those changes that they were seeing in the histological slides that they were taking. They could attribute those changes to the acute or chronic underlying inflammatory process. They already realized that that was the essential patho-physiological process going on beneath the symptoms and the signs that they were registering in the patients. We'll come back to inflammation a little later and the role of osteopathy in the treatment. We've already looked at a piece of research that's just extremely important and should be developed even further. But let's go back to osteopathic palpation for a moment. The palpation, as you all obviously know, provides clues to the underlying mechanism of injury, or pain, or sensitivity, but also especially of articular dysfunction. We rely on our palpation. Now, the palpation, as you all obviously know, provides clues to the underlying mechanism of injury, or pain, or sensitivity, but also especially of articular dysfunction. We rely on our palpation. Now, it's particularly designed to provide a way of identifying the biomechanical factors that are associated with specific pain generators. You want to work out what it is in the biomechanics of the body that may be giving rise to the pain. Now, those findings can lead the operator to explore the potential mechanisms of injury, of repeated injury. How will you determine, let's say, a repetitive strain injury, other than by trying to repeat the very process that has caused the injury in the examination procedure, gently and painlessly? But that is our method of determining the mechanism behind the injury or the pain symptoms. The osteopathic palpation also tries to determine what the cumulative microtrauma might be that result from postural habits or the occupational ergonomic stresses. It's part of your palpatory examination. And lastly, your palpation tries to pick up the somatic manifestations, if they're there, of dysregulated somatovisceral signaling. That last sentence almost got me to abandon osteopathy. I was already in the game in 4 or 5 years. That last sentence, via osteopathic palpation, almost got me to give up the profession. How? Into the clinic, Wernham's clinic, comes a patient with breast cancer. One of these rare individuals that's so scared of conventional medicine that she was willing to forego conventional treatment and let this breast cancer develop into an open ulcer. She must have been 40, 41. I can remember as clearly as yesterday. I can remember the ulcer, the smell. I'd never seen anything like that in clinic before. And there she is saying, get on with it. I don't want conventional treatment. I'd rather die than go through the conventional treatment. Well, that in some ways let me off the hook ethically. She was saying, do what you can. Right. How does it relate to that last sentence? I thought, wow, once I got over the shock, I thought, this is going to be interesting. Let's look for the somatic manifestation of this gross disease. It probably stands out a mile. I'll start to look in the segmentally related areas, which will be from about D3 to D7. Somewhere in there, I should definitely find clear somatic manifestations. Nothing. Examined her spine, it seemed beautifully healthy spine. There were probably secondaries in the spine already, at her stage. Nothing. Neither the palpatory connective tissue changes that we've talked about, nor articular changes. Nothing. It seemed like a healthy, no temperature changes, no pseudomotor changes that I could pick up. And I wasn't bad after 5 years in practice. I wasn't a total idiot. I was stunned to my roots. Every doubt I had about osteopathy came to the surface, and I had doubts for many years. Every doubt came to the surface. I was shocked. I was in a state of shock. And something very strange happened, which has happened many times in my career, when I've had a serious clinical problem. Within days, sometimes within a day or two, I happen to look for an answer, or not even look, but happen to be reading an osteopathic text, usually one of Little John's, and there's the answer. I was reading a Little John text within a day or two of seeing that patient, and suddenly, and I wish I'd have kept the exact reference, he says, not every patient who has a serious disease has a somatic manifestation. You cannot imagine the relief that sentence provided me. It was like a, what's it called, a numinous experience. It's like a better word, the road to Damascus experience. You know, even the great man himself couldn't find somatic manifestation in some diseases. He mentioned one or two. Tuberculosis is what he mentioned, actually. Well, who am I to not necessarily find it? But that wasn't the end of the story. Here comes the great moment, as far as I was concerned, in reading that text of Little John's. Not just what I just suggested. He then goes and says, that doesn't mean that you're removed from your obligation from treating the patient. He doesn't say so in so many words, but he says, go back to your pathology, understand what is the pathology going on in that disease, and work it out for yourself, what you're supposed to do to help the body's immune response. Do you get it? He's saying, act and work like a physician. Know your pathology to work out which drug to give to help the symptoms sufficiently so that the body's self-reparative process can get on with the work before killing it. And since that day, I have very often had to go home, or go on the internet, and work out, either via Mervyn manual or something on the internet, what is the pathology behind this person's disease, and how may I, in theory, affect it with the osteopathic treatment. And it's amazing how often it approaches what the drug approach is. Or I work out the drug approach, or I read the drug approach, understand the biomechanical mechanisms involved in that drug's active action on the body, and try to see what I could do osteopathically that may have the same neurophysiological effects. It's either sedating or stimulating. Drugs are either having a stimulating effect or a sedating effect, unless it's an antibiotic. But even there you can work out the osteopathic approach based on the drug regimen that will be given to tide the patient over the dangerous acute stage. I didn't see that, just to finish the story, the cancer patient didn't stay with me very long. I have no idea how soon afterwards she lived, or whether she had a recovery, which does happen very rarely, but there are spontaneous remissions. I don't know. It wasn't the case that I could follow up or manage to follow up. Now this is one that you all realize. Most of the time our osteopathic palpation is done to determine the pain-generating tissue. And often, if we think we've found the place that is the pain-generating tissue, it's confirmed by an effective therapeutic response. Does what we do produce relief? If so, then we may probably have been right in having identified where the pain-generating tissue was, even temporarily, if the response is positive. So, osteopathic diagnostic palpation seeks to identify any impaired or altered skeletal, arthrodial, or myofascial dysfunction, known as somatic dysfunction. Anything that could be adding to the nociceptive load. I recently had to talk to the orthopedic department in the hospital. I and one or two other colleagues from the pain department, and I presented them with this statement. And they can understand that immediately. And the other thing we try to do is locate any related neural, vascular, or lymphatic elements that might complicate underlying pathophysiological conditions. And that needs a little more explanation, which we'll go into shortly. And that's where it's all happening. It's a beautiful picture, I thought, when I first saw it. What's going on in the fascia is our bread and butter under our fingers. And your palpation of the fascial changes that we've mentioned already is the key to accurate diagnosis. It's the major site for the body's immune response to injury, to inflammation, to infection. It's all within the cells and matrix of the fascia. For example, extravasation of fluid into the extracellular space within that tissue during inflammation and the consequent presence of edema is what you'll pick up with your fingers. It'll alter the tissue composition and texture, sufficient to be a palpatory abnormality, both in the earliest acute stage as well as in its chronic form. Let's have a quick look, in case you've forgotten, what is the inflammatory process and cascade, and how does it produce a compartment syndrome effect? Let's have a look at it just very quickly. chemical mediators, as you know, are released in the fascia to stimulate wound repair and tissue growth. However, many of these mediators, prostaglandins, FP, bradykinin, 5-hydroxytryptamine, increased decreased pH, increased hydrogen ion concentration, histamine. Many of these mediators also stimulate nociceptive nerve endings. The subsequent changes of signaling sent into the spinal cord. The lowered threshold of the nociceptors contributes to the hyperalgesia, frequently reported at or close to the site of the somatic dysfunction. Now, the hyperalgesia will inevitably provoke local as well as more widespread, greater or lesser degrees of myofascial contraction. Now, the presence of inflammation, and especially edema, may result in neuro and microvascular compromise, producing what you all know as compartment syndromes. Compartment syndrome-like effects and a further exacerbation of the local hyperalgesia. Now, you all know compartment syndromes. Your carpal tunnel, there's a classic example of compartment syndrome condition as a result of accumulation of edema in a confined space in which there are vascular and neurological structures. You all know your brachial plexus as a compartment syndrome, and the very confined site of passageway between the clavicle and the first and second ribs. And that's where my colleagues are injecting day in, day out, hour after hour, bang in there, bang in there. It doesn't last very long, most of the time. And then, after the third or fourth injection, they dare not inject anymore because they realize that they're going to do damage to the connective tissue. Steroids keep going in. God helps the connective tissues afterwards, years afterwards. And so they send the patient to me, one of the other colleagues that are not the neurologists or the anaesthetologists. So you get them as a last stage, and they're very difficult to treat at that stage. It's the challenge of the work. You know your piriformis syndrome. It's a compartment syndrome. Why does it suddenly affect the sciatic nerve so radically and dramatically? Because of the changing histological conditions I just talked about. And you may know the neuralgia paraesthetica, where this very precise area becomes hypoalgesic, numb, insensitive, or it can be hypersensitive, but that's rare because of compartment syndrome effects through the compression forces at the inguinal ligament on the lateral femoral cutaneous nerve from L2, 3, the lumbar plexus, branches of lumbar plexus. But let's go deeper, because basically most of our work in osteopathy is to try to overcome compartment syndrome conditions, whether it's pain syndromes or whether it's constitutional syndromes affecting somatico-visceral reflexes. The next compartment syndrome is the spinal canal, the intervertebral canal. That tiny confined space is a site for space-occupying factors such as edema. If you look at current research on pain, back pain, edema does crop up time again in attempted explanations for certain kinds of back pain syndromes. Edema within the spinal canal. But it doesn't have to be just the spinal foramen that suffers from compartment syndrome effects. It can be outside of the spinal foramen that you get compartment syndrome effects around the rami communicants. which from the earliest days were considered some of the most fragile nerve structures, the rami communicantes, to myofascial compartment syndrome effects. And even more delicate was considered the recurrent meningeal nerve as one of the earliest nerves that's likely to suffer from compartment syndrome effects and edema building up within the spinal foramen. But even more delicate than those structures, even more prone to neuro and microvascular compromise, that's a beautiful term, by the way, are, whoops, where's it gone? Just a moment, I'll give it away. There is another set of structures, even more delicate, even more prone to microvascular compromise anywhere in the body, but particularly there, which is being studied today. Come on, must be the right spot. Do you all know or remember a vasa nivorum? The tiny little blood vessels that supply every nerve? And do you all remember the nervi nivorum? The tiny little nerves that supply the major nerves? And do you all remember the nervi vasorum? The tiny little nerves that supply the tiny little blood vessels? Well, it's actually the vasa nivorum that are being more and more studied in current physiological research on pain. They're not even on this picture, they're so tiny. But they're there in the spinal foramen and around the spinal foramen, and any degree of edema or inflammation or compromise is likely to affect them first of all as pain generators. How does our treatment affect them? Theoretically. Well, we'll look at that in a moment. Moving on to treatment from palpation. Just 1 second. Before we get to treatment, just a quick review. Palpation is an attempt to measure the degree of sensitivity, to determine the tissue texture changes. This is a summary of all we've just been saying. To determine restricted or exaggerated, can be exaggerated as well as restricted segmental motion, or articular motion, I should have said. And the attempt to look for asymmetric motion, or postural asymmetry, or analgesic asymmetry. Oh, sorry. Okay. What are the effects of osteopathic treatment and passive motion? Over the past few decades, the importance of passive motion has come to light by way of extensive research. There's an enormous amount of research published in physiology journals on the effects of passive motion on repair processes in the musculoskeletal system. But you may ask yourself, how may nociception and the effects of inflammation be reduced by passive motion or osteopathic treatment? That's the next obvious question. Now, there are several suggested mechanisms by which passive motion, and specifically sedative, oscillatory, osteopathic treatment procedures, may reduce nociception and the effects of inflammation. Here's one of the most important potential reasons. Passive motion in osteopathic treatment, hopefully, certainly has been researched in terms of passive motion, enhances the clearance time of both pro-inflammatory mediators and edema. Every physiotherapist knows this in theory. It applies to active motion as well. If the patient is able to move rather than stay in bed all day, it'll speed the time of resolution of inflammation if it's careful with the active movement. If it isn't one that causes further injury, pain, it will speed the time of clearance. Passive motion, osteopathic treatment, increases the transmission sending pain inhibitory signaling from the cortical centers. This is a subject that is extremely important today. And we'll look at it a little more deeply later if we get to it. It reduces the degree of compromise of neural and microvascular structures and lymphatic structures. It produces, and we've already looked at some research about this, an enhanced immune response, which will lower the inflammatory reaction or speed up its resolution. And one of the most important pieces of research, or the great massive research that's been done and has been done in the past 2 decades on passive motion and its effects, has been in looking at how it may or may not improve the quality of connective tissue repair after injury. There's been a lot of work on that, and the positive results. And in relation to that, the improvement of the rate of repair. So when your patients come to you with any one of those pain syndromes that make up so much of our work, and you're not sure what you can do for them because they're in such an acute stage, try to remember some of these phenomena that ought to happen if you're patient and quiet and gentle and do not further exacerbate the nociceptors. There should be no such thing as causing more pain to the patient in osteopathy. A mild degree of discomfort is understandable, but in theory, you have to find techniques and ways that do not further irritate the primary afferent nociceptors that are already ringing these alarm bells like mad. So, significant therapeutic effects were found on tissue repair, shown in connective tissue, in joint complexes, and muscle. But furthermore, it was found that passive motion, that is, periodic, moderate stress, is essential for tissue nutrition, homeostasis, and repair. It's a great art, teaching the patient what they can and cannot do, what they should and should not do in the reparative stage. It's a great art. But it's made much easier for us by one simple factor. And you have the patient help you on this one. They are essential, in fact. You recruit the patient by insisting that the factor that will tell them whether they're doing too much is pain. They do not take the exercise or the movement or the passive motion or the active motion beyond the point of pain. The pain is telling them so precisely how far to go at that moment in time. That's where the wound healing allows movement to be performed without causing more destruction and pain. There's a beautiful phrase in Hebrew, which I only read the other day in an article by a very, very clever physiotherapist. I'll use it for a moment and I'll try to find a translation. It's very simple. It says, Kisharon bimkom kosher, which means, oh, you have to help me out. It means skill rather than kosher. Skill rather than effort. Yeah, effort. It's not quite the translation. Skill rather than effort. Let me show you. The patient comes in with an acute shoulder, capsulitis, an adhesive capsulitis. They can hardly raise their arm that way, that way. They can slightly forward raise the arm. The active exercise I prescribe is taken from Qigong, which or Tai Chi. It's ideal for rehabilitation. That is Tai Chi. Qigong is ideal for the early stages of rehabilitation. And the only movement I ask them to do, and I have to teach them to, and I have to do it with them, so they don't do it other than the maximum relaxation, is that. Up to the point of discomfort or pain, and no further. 3 times a day, up to a cycle of 10 to 20, with the appropriate breathing. At a later stage, when it's less painful, moves on to a second movement. Again, not beyond the point of pain. Totally different from most physiotherapeutic efforts at exercise regimes. Totally different. Under good posture, which I have to correct all the time. And it can be done in the sitting position if the patient cannot stand. And there are similar movements for the legs, where the legs need to be activated. Third movement. Now, ideally, they should be up there, but you may only get to there without pain. But you're activating all the synergistic muscles, all the co-contracting muscles, but in a very balanced manner. More important than anything is what you're doing up here. The most latest research on pain is constantly emphasizing brain plasticity. What does it mean? It means that when you have chronic pain, there are visible changes in brain cells in the motor and sensory centers. Changes which make recovery much more difficult, which is what makes a condition chronic. Because the active motor movement is no longer the same because of the changes in those motor sensors in the brain. They can't perform the movements anymore the way they should, because the chronic pain in the earlier acute stages has already frightened them to enter certain arcs of movement. So you've got to, at some stage, very often, to get them out of the chronic pain cycle, you have to teach them how to learn once again to move symmetrically, rhythmically, with a minimum of muscular contraction and with a minimum of unnecessary co-contraction. Almost come to the last of the 6 basic movements. When they get to this, they're cured. If they can do it, they don't need me anymore. Okay? So simple. There's no great fuss, no great sweat in the gym with appropriate breathing. As slow as possible, so they have time to relax the muscles as they use them. Skill rather than strength. That would be a translation. Skill rather than strength. And that, as far as I know, in the most up-to-date research, is the only thing that repatterns the brain motor and sensory centers in chronic pain conditions. Now, I think treatment also helps. There is an aspect to, certainly in classical treatment, where you're getting a re-education of proprioceptors by repeating and repeating and repeating in a rhythmic and very symmetric way movements that have been lost or hampered or affected by the pain and the chronic avoidance of certain movements. So I think you can also blend it beautifully with what you do on the table in terms of leverages that are oscillatory and taking in large arcs of conjoint movement. We mentioned, I just demonstrated, the value of active movement in assisting tissue recovery. Not least following immobilization. 3-minute thing I'm going to show you now. I should have shown it to you earlier when I emphasized the importance of sedation, of dampening the aberrant afferent input, whether it's from a pain syndrome or whether it's from an infection, an inflammatory condition. Your primary primary aim is to dampen the afferent input. And this is what it looks like in a clinical case. It's obviously an infant who featured very classically on the operating knees. We'll come back to that in a moment. Just watch this. Look at this technique earlier on the photograph. And watch what happens to the baby. Slow and steady and precise the hands, and how the whole hand is being in contact. It's not poking. That is classical inhibition. Extremely quiet and sedated, very quickly. It happened to me a few years ago when I was demonstrating this on a baby in front of a workshop class, a big audience like this, and the baby dropped off to sleep under my hands. It was the finest compliment one could get to demonstrate the power of this simple maneuver. It's like the older child. Child's perfectly content. It's almost hypnotized. You can see it from your eyes. It's gorgeous, absolutely gorgeous. Now it's only, I believe it's only when you understand the pathophysiology you're trying to affect that your hands can work like that. I don't believe your hands can work as intelligently until and when it's just palpating. Until and when you can see the pathophysiology you're trying to affect and the histological structures underneath. Let me go back just a minute or two in that procedure okay, to hopefully that was what?
723, is it?
So I want to get back to 723. Second to get into it. Okay, from there. Just to show you, here's using the head and neck as a lever, which is very rare. You have to be very careful. You can't just throw a head and neck of an infant around without causing potential torticollis, but you use it as a lever. It's finding the somatic dysfunction. Look how slow, quiet, and deliberate that is. Look how the knees are used to introduce flexion and extension. It opens and closes its knees. Just the appropriate flexion and extension of the spine. Checking the pelvic base. Even on an infant, it's never walked. Traction. And focusing the traction at the segmental level. You can't see the hands behind. Or general traction to the whole thoracic spine, the lumbar spine. Just letting it hang under gravity with a little swing occasionally if he wants to. And those hands were in the game virtually 70 years. We're looking at him literally last year or two of his life.
Continuously checking the
Yes, that's important. Treating, checking it. Treating, checking. Has any change occurred? Child's resisting a little, crying a little at that stage. So it's even more striking when you become so sedated later on. Mum's helping to keep the child quiet and give the child confidence. Always bring the mother into play somehow by holding a hand or